When you remove that cost issue out of the picture, your focus is just on the patient, which is where it should always be.
You're saying the worry of, did you click the right buttons? Did you chart the right things for the visit to be billable according to the insurance company?
I think it was the day-to-day battle. You end up losing yourself in that, the fighting for a prior authorization. What comes first? Does our family come first? Does my wife come first? Do my patients come first?
It feels good to be cared for by somebody that cares about you.
Which is why I just truly love what I'm doing right now. I can truly say I again have a love for medicine.
Thank you for joining me, Dr. Dhanji, on our podcast today. We've got Dr. John Dhanji, and I'm excited to talk to him today about his practice. He's relatively new to DPC, early parts of this year. Made the switch from traditional family practice medicine to direct primary care. Welcome.
Thanks, Sean. Good to be here.
Yeah, awesome. So help us understand a little bit about you. Where did you practice? How long did you practice? And what made you cut the switch?
So my medical journey or my medical career actually started back in Savannah. Right out of residency, I was given an opportunity to stay on as faculty of my residency program, and did that for 5 years, made it up as assistant program director. Enjoyed teaching, and I still teach now. So I still have medical students that rotate with me in my practice now, which is great. But was in medical education for the start of my medical career, or my professional medical career. And then moved down to Jacksonville, Florida, back in about 2014, and was looking for a traditional family medicine practice. And as it turns out, my chief resident when I was an intern told me about this practice that he was at, which was in a large hospital system that still practiced traditional medicine, or traditional family medicine. So still doing inpatient, outpatient medicine, admitting your own patients. The only thing that we did not do was pediatrics. So it wasn't that true birth to death practice. It was more adult medicine, but still enjoyed doing hospital medicine, and that's what attracted me down to Jacksonville. So something in me that still wakes me up at 4 o'clock in the morning to get ready for work. I think that's ingrained in me, as crazy as that sounds.
Well, you do it for so long, and you can't break the habit.
Yeah,
you know what I mean?
It's funny you say that. It definitely becomes part of you. The one thing that took me so long to realize, being so engrossed in that corporate medicine world, that it actually starts to change your identity. Which is not good at all.
No.
You forget who you really are. And I didn't realize it was happening. If someone would have asked me, "Who are you?" I'd say, "Well, I'm a physician." No, I'm Sarfaraz Dhanji. I'm a husband. I'm a dog lover. I love the outdoors. That's who I am. My profession is my profession. That's my career. It's not my identity. And that's what I did not realize was happening to me. And it took my wife a lot of nudging and a lot of patience to show me that, yeah, that's what had happened to me. And it was an eye-opener for sure.
Yeah. If you don't mind, what, the nudging, and I guess, when did you realize your career became your identity? Or at least, when did you realize that you had adopted the takeover?
So a friend of mine from residency, he works for the VA up in Savannah, and we're pretty close. He comes down here to Jacksonville. We go up to Savannah every now and then to visit, and we get into our residency talk, and we get into our metaphysical talks as well. And
solve the problems of the world.
Absolutely. Absolutely. Paul and I were having this discussion, and he said, "Who are you?" And I just said, well, you know who I am. He goes, no, who are you? And I said, well, I'm a physician. And he was the one who pointed out, he said, Sarf, that's your career. He said, that's not who you are. And it's sad that it took someone else to show me and to open my eyes. I'm glad it was a close friend of mine. But it was an eye opener. It really was. And I didn't realize how much the day in, day out of seeing 22, 24 patients a day, forget the burnout. What about that moral injury that we suffer as well? You know, what comes first? Does our family come first? Does my wife come first? Do my patients come first? I'm very fortunate that my wife is so supportive of my career and supports me that, yes, it is all about the patient. I wouldn't still be married 25 years later if she didn't understand that and supported me in that.
Yeah. So you talk about your daily schedule, 25, 26 patients a day. What else contributed to the takeover, to you identifying as a physician?
I think it was the day-to-day battle. You know, you end up losing yourself in that, fighting for a prior authorization, trying to help a patient who can't afford their medications, trying to help them afford their medications. You know, what's more important? Is it more important for a patient to put food on their table, make sure they have a roof over their head, or take their medication? Right? Well, it's all important. But from the patient standpoint, they're not realizing and seeing what the benefits are of taking certain medications off a potential silent killer like hypertension or diabetes until it becomes too late. You know, it's my job to be an advocate for a patient. That's kind of what I signed up for. I didn't sign up to click little boxes to say, hey, I hope I click right so I can get paid. You know, that's the fundamental problem with where medicine is right now in that traditional fee-for-service world. The emphasis has been lost to the number of patients I can see so I can get paid, so I can make a living, so I can pay off my student loans, so I can provide for my family. The emphasis should be on the patient, and that's where I feel that direct primary care comes into play. I was at a family medicine conference back in, I think it was 2016, if I'm not mistaken, down in Orlando. And a friend of mine from Savannah, he and I were at the same conference. And they had a breakout session on direct primary care. And I said, well, knock yourself out. I'm comfortable where I am. I'm going to go get my CMEs done that I need. This was, I think, September, if I'm not mistaken. The following year, he and his wife changed our practice over to a DPC practice. Pete and I have been in touch ever since, and he's always been after me. You know, you really need to do this. It's right up your alley. It fits your persona, and I was always scared, flat out, always nervous, always scared. How am I going to do this? How am I going to get patients? I'm okay where I am. You know, I was somewhat content seeing those 22 patients a day, and coming home tired, getting back on the computer, working till 8:30, 9:30 at night, calling back patients. And that's what created that identity of, yeah, you're a doctor. You're no longer a human being. You're no longer an uncle. You're no longer a nephew. You're no longer a son. I hadn't spoken to my parents in I don't know how long because of work. And the conversations were short, and I was losing myself in something that I've always wanted to do, but to what end?
I think you just said it right there. In every career and every every life, what you do becomes a bit of your personality and a bit of your identity. But that complete, this is who I am, is a trap. So I think there's, you need to adopt a certain amount of what you do and who you are into your into your individuality. But it can go too far. You're saying the worry of, did you click the right buttons? Did you chart the right things for the visit to be billable according to the insurance company? Or are my recommendations being prudent? Am I helping my patients the best way? Also, at the same time, I assume there's policies and things that you were confined to, and maybe things that you didn't recommend because of such. You think? Yeah.
Yeah, very much. The entire reimbursement model of the RVU is just so patient centric. I gave an example to a colleague of mine when I left the fee-for-service world. I said, if I'm not making my RVUs in a month, I said, the following month, every patient that comes in with a cough, should I go ahead and order a chest x-ray just to bump up my RVUs? I said, that's where the focus is. Right?
The misalignment of incentive.
It's not ethical. It's not morally right to do that. When you shift that focus back to the patient and you do what's right for the patient, you take away that dollar incentive. Wow, everything falls right into place. I mean, this nonsense of clicking a box to say that I'm a great physician. Well, what about asking the patient if I'm a good physician? Right?
Yeah.
What's the bottom line to the patient? Has he stayed out of the hospital? Has he been cared for? Has he or she been cared for? Are messages being answered appropriately in a timely manner? Are labs being ordered and resulted in a timely manner and not sitting in an inbox for 2 weeks on end? Oh, dear Lord, I have this patient. I've got to call back. I don't have time for it. I'll put it off till tomorrow. Yeah. And those
Tomorrow's
messages get
just
lost.
as busy. Yeah.
Correct. So I was basically pushed into a corner, which is what made my decision to leave traditional or the fee-for-service world of medicine. I got tired of working the 16-hour days, and I turned in my resignation. I told my partners what I was doing, told my office manager what I was doing, and when I turned in my resignation, I had no idea I was going to go both feet into DPC. I really thought I would do locums for a little while, and then try and figure out what I was going to do. But I made up my mind that I was going to leave when we were on vacation. We spent a week up in Maine in August. Loved Maine. It was beautiful, beautiful scenery. We had 2 days of rain, and we had a couple of excursions set for whale watching and all that, which we had to cancel. So I'm on my iPad, and I'm looking for non-clinical jobs in medicine. And my wife said, I'm crazy, I'm going to be miserable, and that I would make her miserable if I were to practice medicine. So do what you love to do. And that was it. So we came back, turned in my resignation. I called Pete up in Savannah, and I said, Pete, I'm ready. And he was like, about time, I was wondering when you were going to do this, blah, blah, blah. And he was absolutely instrumental in helping me get up off the ground, as was another friend of mine that I used to work with in Savannah at the residency program. She's now up in Delaware, and she started her own DPC. So these are two people that I've worked with, two people that I've known, and I think the stars just aligned for me to say, yeah, I have to do this. The sad part about all this, when I turned in my resignation, I got a call from administration wanting to know why I'm turning in my resignation. And I said, I can't work like this. I said, you have a system that's not sustainable. I did my 16-hour days when I was a resident years ago. I said, I'm not doing that again. And the gall of this administrator to tell me, yes, I can see you're logging on to Epic early in the morning and you're logging off again around 8:30, sometimes 9:30 at night. That to me was, well, you know my work hours, you know how long I'm working, and that's okay for you. So that showed me that, one, you have no respect for what I do and you don't care what I do as long as I'm bringing in the cash to pay your salary. Because honestly, no one in a hospital administration system is billing Medicare or any of the insurance companies that brings in the cash to run the organization.
Right.
Right? So in my book, all that is overhead. Why am I paying the salary for someone who has no respect for what I do? For my business, you'd be fired in a heartbeat because you're bringing more overhead than what's needed.
Well, you did fire them, right?
I
fired
did.
all of them.
I absolutely did.
Yeah.
I sure did. So I left and spent 1 month getting all my ducks in a row with the DEA, Florida Board of Medicine. Started my own practice up in March 2023. I couldn't believe it took only 1 month to get it all squared away. I opted out of Medicare, and I'll never forget that email that I got from CMS. Mm-hmm. It was a Friday, or it was a Wednesday morning. I'm having my coffee in February, and I check my email, and I get this email saying that your opt-out has been approved. You have 90 days to reverse the action if you so decide. And I said, heck no, I'm moving forward. I'm burning that bridge and never going back.
Yeah.
So opted out of Medicare. And
delete that email.
Yeah, I have saved it, saved it.
Oh, okay. maybe not delete. You printed it and put it on your wall.
Absolutely. So opting out of Medicare was fantastic. Not being associated with any insurance is even better. I had about 80 patients pre-register with me all through the month of February.
Okay.
Which was great. Some were new patients. Some were my previous patients who, as crazy as it sounds, a lot of my patients, I give my cell number to a lot of my patients. So just in case they need to get a hold of me for anything, they could always get a hold of me. But long story short, got the operation got the business up and running, clinic up and running in 1 month, and been growing very steadily. There's not a month that goes by where I don't have at least a handful of my previous patients find me that sign up, which is I'm very grateful to God for that. I think keeping my faith has been extremely helpful in alleviating the anxiety of being a business owner, but I should have done this a long time ago.
Well, that's inspiring. That's pretty cool. Give your resignation, take some vacation, and be like, there's got to be non-clinical stuff to do. But your wife's like, no,
there is.
no, you're not going to be happy. And if you come home grumpy, life's not going to be great for me either.
Well, let me put it like this. Not working the 16-hour days, my wife really loves me now, and my dog really loves me as well.
Oh, good. So that switch helped, I guess, bring back your identity, right?
Yes.
You're still a physician, right? That's still part of you.
And I love what I do now more so than I ever have in the past.
Cool.
This is what I really signed up to do when I was a kid wanting to be a physician. And now I get to do it. I get to do it without any restrictions. I get to do it the way I feel medicine should be practiced, by having those relationships with patients. When I used to teach, I gave a grand rounds lecture on professionalism in medicine based on the core competencies by the ACGME. I think professionalism is the foundation for all the other competencies.
Okay.
And I posed a question to the audience, and the audience were other physicians, attendings, medical students, residents, nurses, and so forth. My question was, or the premise of the question was, we have a crazy job. People that we don't know are putting their hands in our lives because of two little initials after our name, whether that's MD or DO, doesn't matter.
Okay.
So my question is, would you do the same? Would you put your life in the hands of a stranger, not knowing who they are, not knowing their background, not knowing anything about them, just because of two little initials after their name, and entrusting them with your life, something that is very dear to each and every one of us? And it gives you some pause to think about that question and about the gravity of what we as physicians do. And you can't put a time limit on that. You can't put a dollar amount on that. So it's something really interesting to think about. And that's the way I try and practice. So my practice name, Magnus Direct Primary Care, right? So why the name Magnus? I get that asked a lot.
Yeah, it's not your name.
It's not my name. It has nothing to do with India at all. So I was looking for a name that stood out. I was looking for a name that had meaning. I was looking for a name that started with an M. And Magnus means great in Latin. So what I want to do is provide great primary care services to my patients. So that's where the name comes from.
That's cool.
And that's why I try and exemplify. I love the fact that patients have direct access to me. A couple of my colleagues that are still in the fee-for-service world are like, don't patients bother you all the time? And, it's a simple no, they don't. They're very respectful. The text messages I get, I'm really sorry to bother you on a Sunday or on Saturday or in the evening, but this is what's happening. If it takes one text message or 1 2-minute phone call to alleviate someone's stress and anxiety, well, why not? If all they need is a question answered and I can answer it, why not?
Yeah. I mean, you talk about your 16-hour days. That's a lot different than a 5-minute break on a Saturday to respond to somebody or to calm somebody's nerves. And then Magnus, great. That's awesome. Just before this call, in fact, you requested us to push it back because you were offering that great service. You mentioned, hey, can we push this call back 30 minutes? I'm just leaving the hospital.
Yeah.
And I was like, leaving the hospital, that's either not a good thing, or he was with a patient. That level of service, I mean, maybe talk to me about what you offer as a DPC physician.
Sure.
Why were you at the hospital?
So when one of my patients gets admitted to the local hospital here, I will go by and see them. I like to make sure that things are going the way I would want them to go. I like to talk to the physician in the ER, explain the situation, and tell them who the patient is. I have that relationship with the patient. The ER physician doesn't. No. So the ER physician knows the background, the medical history of who the patient is and how I'm involved in that care. It becomes more personalized. Okay. And that's what I like to do. So I will go see a patient in the ER. If I've sent them to the ER, I will go see them in the ER. I will look at their labs and look at the diagnostics that have been done. I'll talk to the physician and the nursing staff and make sure everything's going the way that I would expect it to go. So we're all on the same page. So I act as a liaison between the ER physician, in this case, and the patient. Because let's face it, the hospital staff, the ER staff does not have time to sit down with the patient and talk to them and let them know what's going on. Right? Tests are ordered. They give a brief overview of what's happening. In a stressful situation, it's in the patient's mind, it's going in one ear and coming out the other.
Oh, yeah.
And they're catching this much of it, which is not a lot.
Sure.
And when you're in a stressful situation, you need someone on your side who's looking out for you, again, who's being that advocate to explain the situation, explain the circumstances, and help them alleviate that anxiety in that anxiety-provoking situation. So to me, that I honestly, I would want the same if the situation were reversed. I would want someone advocating for me if I were in the hospital.
Oh, yeah, absolutely. There's too much pain, too much anxiety, too much stress. Am I going to be able to afford this? To really listen to any instructions, any recommendations. Yeah, absolutely. So in a situation, who notifies, in a situation where you don't recommend a patient to go to the hospital, who notifies you that they're in the hospital?
Great question. Usually the patient will call me and tell me, hey, I'm going to the ER.
and you encourage that if it's weekend, evening?
Yes and no.
Okay.
Yes and no. If a patient is short of breath, they are having symptoms of a cardiopulmonary issue, yes, go to the ER. I will see you there.
Yeah.
Okay. I had a patient actually 10 days ago today, 12 days ago today. I've known her from my previous practice. She called me in the morning, and she said I was putting on my compression stockings, and my hand slipped, and I've cut my leg, and my condo looks like a murder scene.
Oh, geez.
Okay. So she called me. She said, can you get me in with wound care? I said, I can, but it won't happen until probably the end of the week. So she told me what happened. I said, why don't you come here? Let me take a look. And if I can take care of it, I will. Yeah. And I said, if I can't, I'll get you to the ER. So she comes in. She's got this U-shaped laceration on the distal leg, left leg. Okay. Took a look at it, and I said, joked around with her. I said, that does not look good at all. So, and it was the same week where I hired my first employee, right? So the timing couldn't have been better. I definitely needed another pair of hands.
Sure.
So I was able to clean out the wound, put 12 stitches in, dress the wound, told her to keep it dry, and that was it. Sent her on her way in about 30 minutes. And saw her today. She sent me pictures along the way to make sure the wound's healing. Saw her this morning, took the stitches out, and she's doing great. So I saved her a wait in the ER. I saved her at least, I would say at least a $2,000-3,000 bill from going to the ER.
Yep.
And I took care of her. I didn't have to turf her off to someone who doesn't know her.
Well, and it feels good to be cared for by somebody that cares about you.
Yeah, absolutely.
The hospital is a very sterile place. You show up, and very caring people, very, they have their heart in the right place, I feel like most of the time. But it's like, but they don't know me, and
right.
And they don't know how I feel appreciated. You knew you could joke with that. If she comes in, oh, that doesn't look good, right? Already bring the tone down just a little bit, and hey, we're going to take care of you here. Oh, and by the way, I've talked to some DPC. There's no cost share for that. This is part of your membership. I'm going to care for you.
Yeah, she didn't have to pay anything extra.
Yeah,
which was even better.
Yeah,
When you remove that cost issue out of the picture, your focus is just on the patient, which is where it should always be.
Yeah.
Which is why I just truly love what I'm doing right now. I can truly say I again have a love for medicine.
That's awesome. That's awesome. And so 2024 is a big year for you. Opened up your practice not even 3-4 months ago?
No. I actually opened up in March 2023.
Oh, I'm sorry. I misunderstood you. Okay, so just over a year.
Just over a year.
Awesome. And I guess, how's it going? You said you just hired your first employee 10 days ago or so?
About 3 weeks ago now. Before that, I was the janitor, the maintenance guy, the receptionist, doing everything.
Yeah.
And doing my own prior authorizations, my own refills, everything. It's getting busy. It's getting busy. My busy days are no longer 22, 24 patients. My busy days now are about, on the high end, about 10 patients.
That's still a lot for a DPC.
It is.
That's in office, 10 patients in office?
I'm sorry?
You said that's 10 patients in your office?
Yeah, on a busy day. Today I had I think I had about 6 patients in the office today. Every day is different. My busiest day has been 10 patients.
Yeah.
That includes in-office as well as virtual patients. So my office hours are from 7 o'clock in the morning to 3 o'clock in the afternoon. And I did that on purpose because I think it's important for granting patients access to care. So someone who needs to make it in before they get to work, they have that opportunity.
Mm-hmm.
I still provide care after hours by appointment or by virtual visit.
Yeah.
So if someone needs to see me after 3 o'clock in the afternoon, and if I can make it happen, sure. Absolutely.
I think recently we discovered most things can be virtual. There's a few things you need to put your hands on, but follow up, even treating some acute diseases, acute conditions, a lot of that can be virtual. And I mean, there's your overhead, right? So a video platform, well, everyone's carrying that in their pocket, basically.
Correct. Yeah.
Right?
Yeah. I've done it off my phone, believe it or not.
Absolutely. Oh, so have I with for my kids and other things. Yeah. Talking about overhead, and we'll just kind of switch gears a little bit. You mentioned, I guess what I want to know is, what do you know about the healthcare industry that we don't understand? Why is it in a negative light? Why is it struggling? Why is health so expensive? If you can answer those kinds of questions. You talked about administrators, right? They're taking your salary, and if they don't have if they don't have respect for you, why are you paying them? Now, you're not their boss and actually handing them money, but you're, as a provider, the revenue comes in through you, and that's how the hospital makes its money. Administrators, what do they do? A lot, but what do they do for the actual revenue? Oh, they increase your hours. They say, Epic, hey, you sign on early and you sign off late. Okay, thank you. Thank you for that.
Thanks. It's not like I don't know that.
So where did the healthcare system go wrong in your perspective?
I think we as physicians let this happen to ourselves. I think we gave up control of our profession a long time ago, and now it's impossible to get back, because it was ingrained in us that you're a doctor, you need to practice medicine, we're the business people, we'll take care of everything else. Well, if you sit back and think about this, it kind of makes sense. But it also puts limitations on who we are as physicians. We are probably the best and the brightest, probably the most hardworking group of people in society. Why is someone telling me that I can't be a business person, or that I can't understand a simple balance sheet or an income statement? I can do the Krebs cycle in my sleep. I love biochemistry, by the way. So, if I can do that, I think I can understand how to run a business. So I think we've been given this false pretense that we don't know how to run a business. We don't know anything about how to run a business. All we know is how to manage patient care. I think that's a big part of it. I think another big part of it is insurance companies have too much control. But when I write a prescription for a medication that I know is going to be beneficial for a patient, why do I have to jump through the hoops of doing a prior authorization? Doesn't make any sense. So now you've got an insurance company counteracting my medical decision making. Right? That sounds kind of like practicing medicine.
Yeah.
Without a license. Okay.
Without a license and with a heavy bias for financial stability.
Absolutely.
Yeah.
Absolutely. Trying to regain that control is, I don't think it's going to happen. I think it'll happen from an individual standpoint. I think we need more direct primary care physicians. I am more than happy to help any physician open up their own practice, an independent practice, whether they're primary care or whether they're specialty care. I'm a big believer in getting back control in the hands of the physicians so we can actually take care of patients and not feel burnt out, that we don't have to keep fighting the system to help take care of our patients. When I was getting ready to, when I was doing my research on DPC, there was a book that I read by another physician who's a leader in direct primary care, Dr. Doug Farrago. And great book. He's written a couple of books. I read one of his, and in one of his books, he has a chart. And he has this chart going back from the Department of Labor and Statistics, which shows that from 1970 to 2009, there's been over a 3,000% increase in hospital administrators, or administrators in healthcare. During that same time period, there's been about less than a 5% increase in the physician workforce.
Wow.
That's astounding.
Yeah.
So you look at where the cost of care, why the cost of care is so high, and why someone like me who's been out of school for the past 22 years, who's still paying back his student loans, that's a problem.
I mean, you touched on quite a few things. Administrators, insurance companies, not allowing the patients to really have purview of their own health. It's to the dictate of an insurance company. Physicians being restricted within those parameters, right? Prior authorization before you say, "Hey, I know this medication is going to be helpful for this individual." It's an inspiring message, and I'm on the same side as you. Business. I'm a biochem major as well, and so I love. I love the systems, and I felt like I did take some business classes. I took some biology classes, obviously, and I felt like the business classes were, they made sense. It was like, oh yeah, I can rationalize and put my head around that. But some of those biochem, I was deep into some, protein structures, and I'm like, this is going to take me some time to get this down to understand what I'm talking about. But the basics of business, I think physicians can take that back, and that's what you're doing as a DPC provider.
Yeah. The one thing I will say, there's an organization called SCORE.
Okay.
It's a free service, which is even better for someone who wants to start up their own practice. And the one thing I really liked about SCORE, I forget what the acronym stands for, but it's people in business that are active and retired that are willing to help you out to start your own business or even expand your existing business. Found out about SCORE through one of my patients who decided to be my SCORE mentor and decided to follow me into my new practice. So he and I still meet on a weekly basis virtually.
Yeah.
Now the talk is about marketing, and if there's one thing I wish I would have done was taken at least one marketing class back in college. Really would have helped.
Marketing is a bit of a bear, I guess. I will give you that. But it changes, right? I mean, marketing 10 years ago is different than it is now.
Definitely.
Inspiring message today. Thank you for your time and for your experience. I
appreciate the opportunity.
Yeah, you're very, very welcome. Everyone else, thanks for viewing, and we'll see you next time. Bye-bye.
Thanks, Sean. Bye-bye.